Yeah, and this is a pickup of a second part of a talk that we did last week, particularly talking about trust in artificial intelligence and how that appears to both doctors and patients.
But the future of medicine is possibly the view is we will be treated by a robot, which seems to be in people's thoughts. But before we talk about that, uh, we need to talk about locus of control in healthcare. And this is a question that I always ask patients when seeing them for the first time. And it's when medical decisions come up, what doctor patient style do you feel most comfortable with? Number one, the doctor should tell me what to do. We call that a paternalistic doctor patient relationship. Number two, the doctor and I should decide together. We call that a shared decision making. And number three, I will decide after I have the information, which is a patient empowered view. And this is important for the patient to understand what type of patient they are, but it's also important to understand from a doctor standpoint. For example, a lot of doctors feel that the patient should listen to their recommendations, and they're very paternalistic, as I'm sure uh, everybody realizes. But doctors have moved in recent years to more of a shared decision making style, and some still have difficulty dealing with the third type of patients. And this locus of control has really evolved over the last few decades as it impacts the new information systems that have come about. And that's shown in this slide. Where in the 50 years ago, almost all the patients just listened to their doctors, and it was probably a fifth that wanted shared decision making. But as time went on, the small number of patients who just said, "I want the information, I'm going to decide." And if you notice that that percentage of patients has really increased dramatically over the last few decades. And I think that that's where we are. It's important to understand how artificial intelligence is going to impact this. Uh,
Yeah, this is really important, and it's especially important that the patient and the doctor are both aware of what type of relationship they want to have. I know where I was practicing in northern Maine, we were very, very short of ENT doctors, and it would take a long time for my patient to get into the ear, nose, and throat. And after several patients came back with reports, I started warning the patients that this is what's going to happen. You'll go up to see this gentleman who is an excellent ENT, but he trained in Eastern Europe. And he told a couple of my patients who gave him some pushback about his recommendations. He said, "You misunderstand. This is not a democracy. This is a dictatorship." And a couple of patients came back very upset to hear that from him. And so it got to the point where I would warn the patient and say, he's an excellent ENT, but be aware that this is his style. And before I refer you up there, if this is not going to be something you can deal with, let me know and I'll try to get you an appointment in Boston. So it's really important to be aware of that and be aware of your consultants' styles as well.
Absolutely.
So this is a slide I actually took. I went to the drugstore this morning for something else, and I was walking through. I thought about this podcast we're going to do today. And when we talk about locus of control, I think one of the things that makes it so much more difficult than when I was in training 40 or 45 years ago is that there are so many choices available. And this is the vitamin rack at the local CVS. And I've circled at the top because we were talking about trustworthiness um, at the last episode. Uh, it says at the top, truth is the most important ingredient. And look at all the choices you have for vitamins. I mean, this is mind-boggling. And this is just the vitamins. Across the next dial, there's cough and cold. The next dial behind that, just as big or twice as big, is a rack full of digestive options. And I've been to Europe, and a couple times I've been into pharmacies in the UK or in Spain. And what you notice in those pharmacies is there are no over-the-counter medications. what's out on the shelves is cosmetics and soaps and perfumes. And if you want a sunscreen, in Spain, you go talk to the pharmacist, and the pharmacist will say, "Okay, you've got very light skin, and you'll be walking every day for the next 10 days. You need this particular sunscreen that's going to be high potency and really excellent." And they actually prescribe the sunscreen for you. Similarly, in the UK, I wanted to get some bacitracin ointment for a cut, and that was actually prescription. You cannot buy that over the counter in the UK because it's an antibiotic and they're worried about antibiotic resistance. So um, in America, we have this plethora of choices, so many choices to make. I call this choices and voices. So not only do you have lots of choices to make, and this is considered one of the great things about America is you have all this choice and you have all this freedom, but now you're also getting messages from advertisers, from the news, from the media, now from social media, and now you've got the AI you can go to as well as Dr. Google to get more recommendations or more advice about what you should buy and what you should do. The key thing about this in terms of AI is that it's not just the AI that's doing it, but we should all start to be more aware of the cognitive overload that this occurs. It is a lot of work to make a decision. We know that if you have more than 6 choices, most people want at least 5 or 6 choices when they go. But if you start getting up over 10 to 20 choices, the cognitive overload becomes so heavy that people will often just walk away and not make a choice at all. Or if they've chosen something that maybe they've been using for a long time or that one of their family members used for a long time, they're just going to go with that default choice because it's too much mental work to have to make a new choice. So when we think about AI in healthcare, here's another source of information, and the information that you get is often at a college level of reading. So for a lot of patients, it's difficult to wade through in the first place, and it's just one more source of voices and choices that can come into the patient decision about how to take care of themselves and how to deal with the medical system.
Indeed, the locus of control has certainly changed now, such that I would suggest that the majority of patients are really just want the information and they're going to decide. And I think we've seen that with vaccine hesitancy and other forms of um, of challenges to physicians.
Yes, and this is not particularly going to be helped by artificial intelligence in terms of chatbots. I read a recent study where um, topics that have a lot of medical information, medical misinformation out on the internet, such as vaccines, such as topics about exercise, um, uh, other topics that tend to be controversial because the chatbots are harvesting information off the internet. Um, it tends to be garbage in, garbage out. So that 50% of the time, uh, with these controversial areas of advice or healthcare, if you're looking up advice about diet, 50% of the time, the advice is going to come back problematic when reviewed by medical experts and looking at the actual science and actual knowledge base, because there's so much chaff out there. You can't separate the wheat from the chaff by just using a general internet source of reference for the chatbot.
So let's look at what AI systems can do for healthcare. And I think the first thought is they can help with the administrative issues with systems that administer patient care. Certainly, calling back patients who have elevated um, hemoglobin A1Cs, and certainly triage systems for appointments and scheduling. I think these are starting to come in, and we can all use them profitably because it's easier to get appointment. Sometimes if the chat bot is really good than sitting on the phone for 30 minutes waiting for a live person. So I think these types of systems are going to be be helpful. Don't you agree, Chuck? Chuck?
I do, yes. And this whole series of podcasts and some of the articles we've written started um, when I emailed you and said, I'm not sure everybody understands what AI is, and we all think about large language models or generative AI, the Chat GPT type of systems when we talk about artificial intelligence. But in medicine, we've used intelligent systems, intelligent support systems for years and years and years. And I think one of the first systems that I thought was really helpful was when I was in private practice in Washington State in the 80s. We had a paper system for doing all our appointments, and it was really hard to look ahead and say, you know, we want to put you into appointment in 6 months, and what's the scheduling going to be like? We had to make up the papers that far ahead. Um, in order to be able to be flexible, and then if you changed the appointment, you had to get in there. You had to do them all in pencil because you had to erase them with an eraser. When we went to a electronic billing system, it came with an appointment system, and we were able to more easily schedule appointments and call patients back, remind them to come in for their appointment. So, is that artificial intelligence? Well, it's a computer-based system that makes the workflow go better. And I think when we talk about intelligent support from computerized systems, we need to be looking at workflow in general.
Agreed. So the next type of system are expert reference systems. And what they do is they have a limited but highly reliable data set. And you can count on getting the same response because they're hard coded into doing an organized activity that's reproducible. So there's not any hallucination because the coding is such that it's it doesn't change. And these systems are scalable and they work wonderfully, and can work for years. And I
Right.
think
And
you've
the,
had
the
experience
evolu-
with these.
yeah, the evolution of this is, again, like the textbooks I had in Washington State. I was really excited at that point to get a Scientific American Medicine textbook, which came every month with new updates. And you pull out the pages that were wrong and put in the pages that were
Oh
updated
yeah,
so
I
that it,
remember
it
that.
stayed up to date. And then we went to more online systems where we had online textbooks that you could search using a search tool, and then references like Dynametics and UpToDate, which are updated as soon as the paper comes out. The editors update these textbooks, and you have to subscribe to them. But it's much more easily to find the answer to what you need with a textbook like this. And we know that a lot of the AI systems are starting to be trained on this type of reference material. Open Evidence is a really good example of that, and it gets its information from a whole wide array of reliable medical publishers like the JAMA and the New England Journal of Medicine and Mayo Clinic. Um, and so it has a limited data set, and it is able to answer 100% of the USMLE doctor examination questions because it has the textbooks, that
Right,
it's been that
right.
it's
That it
been
can
trained
research.
on. So, when we look at human memory is really fallible. And, if I ask people, what'd you have for lunch last Wednesday, they're not going to be able to remember because your brain is just not designed to do that. Your brain is designed for pattern recognition. It's designed to look um, at, at risk management, and it can take a whole lot of factors and put those together really well, but it doesn't remember really well. So using computers to remember things and using our own brain for analysis and analytics, that's the best combination.
Absolutely. And the next form of AI that we know about is this decision support systems. And we've had these in our electronic record systems for many years, where if you prescribe a drug and it contraindicated, then it comes up with a red box. It'll give allergy information and also drug formulary, so you don't prescribe a medicine that costs $4,000 when the patient's insurance can actually get one for $6. And also it will allow flowcharts for certain specific problems and diagnoses. I remember when we first got these systems, and most other offices didn't have them. A patient that I'd cared for a long time came in with her daughter, who was um, who, she was dizzy and had some um, weakness, and people in their 80s that have those symptoms are quite difficult. And after examining her and her vital signs, I I told the daughter um, that the reason she had those symptoms, it was a side effect of the pain medicine that the orthopedic surgeon had given her for her back pain. And the daughter was pretty upset. She wanted a consult to a neurologist for dizziness and weakness for her mother, which is the reason she brought her in. I said, I don't think she needs to go to a neurologist. You just need to stop the medication. Well, she was very upset and didn't believe me. I said, well, okay, watch this. And I tried to prescribe the medicine that she was taking uh, in my system, and a big red box came up on the screen. And the daughter and me and the patient looked at it, and it described exactly the symptoms the patient had. And she just looked at me and said, "Well, how come the orthopedic surgeon didn't know this?" And I said, "Well, he prescribes a lot of medicine. He's not a internist or a family doctor. They give out pain medicine. They're not conditioned to work with the many different complex problems of some of these people. He's not looking at the whole patient. He's just looking at the back pain." And I was able to avoid the neurological consult as a result of that software. And that's how it can help us to not make mistakes and look for those types of problems whenever we're prescribing medication.
Yeah, the research on this is interesting, and it is kind of mixed. The drug interaction, particularly, there's been a lot of research showing that there can be alert fatigue if it's not set up correctly for providers, so
Right.
that 33 to 96% of alerts for drug interactions are just ignored. So this becomes, and this is one of the lessons learned when we start to talk about automation and decision support and large language model support in our practices, is how is it actually integrated into the care of the patient. Drug interaction programs have not been found to reduce the rate of errors in the hospital when it comes to medication errors. And why is that? It's because in the hospital systems, things are so complicated that most often what happens is the nurse goes to the wrong patient and gives the right drug to the wrong person. So a drug interaction program is not going to stop that. You have to have a separate system to make sure that the identity of the prescription and the identity of the patient match up before you give that drug. And likewise, a lot of the uh, allergy information and drug formulary information, if it's not accurate in the chart, if you don't have that allergy in there, or you don't have the diagnosis that's going to kick off that um, that alert, then it's not going to help you. And I saw a patient last week who has severe sleep apnea. He weighs over 450 pounds, and he was on gabapentin. And why would gabapentin is contraindicated in that situation? It makes you very sleepy, and you don't want anything that's sedative if you have sleep apnea. And yet, I looked at the chart, and sleep apnea was not on the problem list because it was a new diagnosis, and this patient had received this for his back pain, even though he should never have had that. So again, garbage in, garbage out, and how you set up the alert and the workflow, who's paying attention to that, how much attention we're actually consuming in order to do the interactions and to keep things safety. That's a key part of how it's implemented. So the
Absolutely.
system, yeah, the systems are great, but how they're put out on the ground is the key part.
Absolutely. I think that's well said in that the information in the electronic health record has to be perfect in order for the systems to work perfectly. And you can't blame the technology if the humans have put the wrong information in, or it's somehow been not checked afterwards. But decision support is going to be helpful with AI. The other kinds of expert systems that we've seen starting to come into healthcare are the computer aided diagnosis. And these have had mixed results as well.
Yeah, I want to talk about mammography, and particularly computer-aided diagnosis in mammography. So this came into play around the 1990s, and then in the early 2000s, Medicare said, "Well, we'll pay for additional fee for the computer to go through and help the radiologists find spots in the mammogram that might be cancer and look at them more carefully." So there a lot of lobbying from the women's health and the breast health people got this passed, and so computer-aided diagnosis and mammography took off. But when we look at the history of that, there are some lessons. One is that the there was what's called automation bias, and the radiologists started looking more closely at all the little circles on the mammogram that were the computer said you ought to look at this. This is suspicious, and they weren't looking at the
Right.
rest of the breast so carefully, and so they would miss some things. So the accuracy actually of the mammograms went down when you combine the computer with the physician in that setting. The time it took to read a mammogram went up, so they were less efficient. And when they came around and compared the computer systems versus what they call double reading, where one radiologist reads the mammogram and then it's read by a second radiologist, so they double check each other. The double check system by two human beings came out superior to the computer system. So the computer systems are still available, but now they've been switched over from a rule-based system, which says, well, just look at spots that look like this, to the automated large language model, the artificial intelligence, looking at the whole breast mammogram and saying by training, saying, by being told which areas are most suspicious, it now knows what to look for, and now sensitivity has improved, and the systems are much better than they were. Now, how the radiologists are responding uh, to these improvements with AI, we don't really know yet because the studies haven't been done because it's so new. But at least we want to avoid some of those, the automation bias. The other example I have about that is that EKG machines are reading the EKG for looking for heart attacks and atrial fibrillation and other abnormalities of the heart. If they read it incorrectly, if the computer says this is a atrial fibrillation and the computer is wrong, actually that's accepted by 43% of cardiology fellows and by about 58% of non-cardiology fellows. So if the computer tells you a wrong diagnosis, we're much more likely to not be skeptical of the computer, um, as we should be, and let that slip by. And this is a real concern about automated EKGs because there can be significant harm in missing uh, heart attacks or diagnosing heart attacks where none is occurring. So that's still being worked on by by our cardiology folks. When I read this, I started in my own EKG reading. I started not looking at the computer to begin with, at the computer result. I would just look at the tracing and go through it mentally myself, and then I would look at the computer reading afterwards to check on myself. And I found that I'm less likely to be biased by the computer, and I'm less likely to let the computer tell me it's atrial fibrillation. I look at it and go, no, that's artifact. That really is not atrial fibrillation, and not fly off the handle.
Right. You really do have to look carefully at them. If you, in the case of an EKG, you have all the information right in front of you. With some other examples of the computer may have more information than you have. So there's a difference in how you use these things depending on the workflow, just as we've talked about. And that's really very specific in different specialties and different office settings, the hospital versus ambulatory medicine, specialists versus primary care doctors. So there's a lot to be said about this workflow integration issue of these systems. And that's what really makes it hard. And that's why doctors are not going to be replaced by robots anytime soon.
I agree. I agree.
So the next form of system that that we're going to think about are the large language models, and these have certainly been a a step up in terms of AI. It's what most people think of: Chat GPT, Copilot, Gemini, Perplexity, even systems that work in specialized areas. But they can do some things very helpful. They are excellent at objecting to um, pre-authorizations. They're really good as we talked about last week. And with a few bullet points, I can create a letter to a patient or a specific handout that are good. And I think they're going to be used for more than that as time goes on. Wouldn't you agree, Charles?
I do. And I think my point here is that I don't think large language models are really ready for prime time in making medical diagnoses, and particularly in trying to decide what's wrong. They're just not well designed to be able to make a differential diagnosis. And by that I mean that's when a patient comes in and says, "I've got chest pain." We make a list in our heads or a list on our chart of all the things that could possibly be wrong, and then try to match them. Look at the patient's risk. What is the risk the patient actually has this? And from high risk, it might be something like, this patient might have a blood clot in the lung because they just took a long car trip back from Florida to Maine, and they're on estrogen, and they have other factors that would make them likely to have a blood clot. And then, is it just the flu? Is it chest pain from indigestion? We make a list like that. The research says that computers are terrible at doing that. They miss the differential diagnosis, important things on that differential diagnosis 80% of the time with these large language models or generative AI. So we don't really want to let them do that at this point. I think where they're good, and the story I'll tell about this is my wife recently went to see the ophthalmologist and is talking about maybe getting cataract surgery and having intraocular lens placed. And I said, you ought to know what your options are before you go in there and talk to them. And so I asked Open Evidence, and I asked a bunch of other of these chat bots, just for my own interest, to outline. I said, what is the best intraocular lens for a patient who has cataract surgery? Just a simple query like that. And you get, again, this is the chatbot going to a reference system where they're not having to do a lot of analysis. They're just looking at what the literature says or what the science says, and you get really great printouts of what the pros and cons are. And really, all of the chat models that I looked at came out pretty much the same. They said, it depends on what your priorities are, what your values are, but there are about 4 choices here of different types of lenses, and here's what might help you decide which one to choose. So we talked about voices and choices at the beginning of this talk. I think this is a really good example of how you can use the chatbot, the generative AI, to help you make a choice by giving you information in that shared decision making, or actually the patient saying, "Give me the information, I'll make my own choice." That style of decision making, which we see more and more patients going to. I think the chatbot can be helpful for that, as long as we're not asking it, "Hey, I've got chest pain, and what's wrong with me?" That's what the chatbot is stealing a job that used to belong to WebMD at 1 a.m. Scare you to death.
Right. So I think what you're saying is that if the large language model can be based on a more fixed set of data, and I think what you described is the domain of intraocular lenses. That's way better than all of the internet, because you can see how the interpretation of that data by the computer would be so focused that it would be very accurate. Whereas when you try to interpret data that's from the World Wide Web, as they call it, it's a lot. I mean, and as a result, it takes the preponderance of the evidence, but there's so much noise out there that it can get confused and give some of the wrong answers, which I think will be corrected over time as we develop these models that are more evidence based and have less wrong information included in them. Well, with that, we will end our session, and thank you, Charles, for helping out this week. And we'll be back with our next session about healthcare and artificial intelligence.